Thank you. So the aim of this audit was, this is the first cycle, to determine this is the post-operative bloods, like protein bloods, kidney function, electrolytes, and hemoglobin level in elective patients who had primary arthroplasty surgery, either total hip replacement or total knee replacement. So the aim of this audit was to see if we can do like THR or TKR as a day case without need for doing post-op bloods. Current practice in Derriford Hospital, all patients should have day 1 post-op bloods. That include the full blood count UNEs and HGFR. The question is, routine day 1 post-operative bloods testing necessarily, or this can be just omitted and to avoid delaying discharge. Now, this study was retrospectively identified patient using our system that we book patient on theater using Blue Spear. We use the ICM to check the blood results, and we use the baseline, like pre-op bloods, to compare it to the post-op bloods. Collected pre-operative baseline, like we said, and compared to the 24-hour post-op bloods. Review discharge summaries. Also, we have reviewed the discharge summaries to see if there was any medical input for this patient during their admission to correct any abnormalities happened post-operatively, or if there was any manipulation or like changing to their medication. So the study period was July to October 2024, and the total patients were 250. The inclusion criteria was patients who had only primary THR or TKR at Derriford Hospital. Exclusion criteria: patients undergoing revision THR, TKR. Results. So we had, regarding hemoglobin level, we had only 1 patient who had significant drop in hemoglobin post-op and required blood transfusion. And however, this patient, to be honest, the significant drop was both from surgery itself, but also this patient developed cafe ground vomiting, upper GI bleeding, led to drop of hemoglobin to 73. And this patient had OGT, which confirmed erosive like gastritis as a cause of the bleeding. So there were 2 factors in this patient that leads to this significant drop in hemoglobin, which is the operation and also the blood transfusion. So only 1 patient had blood transfusion from the 250. Regarding the electrolytes, as you know, like hyponatremia, we can classify it as mild, 130 to 135, moderate, 125 to 129, and severe below 125. Total patients who had post-operative hyponatremia were 29 patients, accounting for 11%, and 16 of them were having mild hyponatremia, required no intervention. 9 patients had moderate hyponatremia, and 4 patients got severe hyponatremia. In both groups, moderate and severe hyponatremia, these patients required intervention. That means we have done hyponatremia like investigations, and also we stopped some medication that might cause this hyponatremia, and some of them were started on fluid, like hypervolemic hyponatremia and hyponatremic hypovolemic hyponatremia were also started on fluid restriction. So there were intervention for these patients for the moderate and severe. There was no patients with hypernatremia. Regarding the potassium level, as you know, hypokalemia can be classified into mild, moderate, and severe. And as you know, like moderate and severe can lead sometimes to life-threatening consequences for the patients. So the total patient who had hypokalemia post-operatively were 3 patients, accounts for 1.2%. 2 patients were having mild hyponatremia, and only 1 patient had severe hyponatremia, 2.8 millimole per liter, which required intervention. So we started these patients on IV potassium and also ECGs and monitoring of potassium. So, yeah. Hyperkalemia, on the other side, can be classified again, so mild, moderate, and severe. We had only 2 patients who got hyperkalemia. 1 patient had mild hyperkalemia, and the other got moderate hyperkalemia, which required also intervention. like ECG and also repeating bloods on the next day, and also starting treatment for hyperkalemia. Kidney function. Post-operatively, we had 3 patients had AKI stage 1, which accounts for 1.2%, and these patients required monitoring their bloods. And also, we stopped the nephrotoxic medication, and also they were given IV fluid to resuscitate and correct the kidney function. So key findings, while most patients had stable hemoglobin level, we had only 1 patient who required blood transfusion. Electrolytes, there were 37 patients who had electrolyte abnormalities, including 29 patients with hyponatremia, 3 patients with hypokalemia, and 2 patients with hyperkalemia. We had 3 patients with AKI stage 1, which all corrected with modification of medication and resuscitation. So recommendation, so as our cohort patients operated for elective hip and knee replacements are surgically and aesthetically challenging, like we have patients with a high BMI, multiple comorbidities, and this would increase the risk of perioperative complications, including fluid and electrolyte imbalances, AKI, postoperative anemia. So this would highlight the importance of close monitoring. So post-op bloods showed that early detection of complication, ensuring safer patient discharge, and flagging issues to the GP to follow up if needed. So while addressing these abnormal results might cause slight delay in discharge, because these patients were the moderate, for example, moderate electrolyte disturbances required 1 or 2 days more, like admissions to correct the electrolyte abnormalities. The patient who got AKI also admitted for 1-2 more days to correct the AKI. Although this caused like delay in discharge, but however, this prioritized patient safety, ensure optimal post-operative recovery. So there was also some like plan if we can move from day 1 to day 0 bloods to help earlier discharge. But then we discussed with the anesthetic team, who said that patients who had GI and a lot of anesthetic medication that will be, and also they will be given a lot of IV fluid intraoperatively. That means the electrolyte imbalance might still be unclear on day 0. So this recommended to do bloods on day 1 rather than day 0. The second part of this audit, we are talking about the assessment of hip fit protocol X-rays templating for patients with neck or femur fractures requiring total hip replacement. So this is just against local guidelines, trust guidelines that we use. As you're aware, that national guidelines now for total hip replacement, according to January 2023, we should consider total hip replacement rather than hip hemiarthroplasty for people with the displaced intracapsular hip fractures who first were able to walk independently out of doors with no more than the use of one stick, and also do not have any condition or comorbidities that makes the procedure unsuitable for them, and also they are expected to be able to carry out activities of daily living independently beyond 2 years. Now, hip fit protocol that we use in our hospital is any intracapsular neck or femur fractures that we're planning to do total hip replacement for them should have a hip fit protocol. That means they should have X-rays which include internal rotated hip and includes both hips to facilitate the preoperative templating in the ED department before moving this patient to the ward. The aim of the audit is to check if the assessment of hip fit protocol templating before surgery, if this patient had X-ray or not before surgery, timing of this X-ray when they were done, and also adequacy of the X-rays before surgery, if they were including both hips and the hips were interrotated or not. So we used our systems to find these patients. In June 2024, we checked Blue Spear and PACS to look at the X-rays. So we found that over 6 months, we had 270 neck or femur fractures. 144 patients got hemiarthroplasty, hip hemi, 76 got DHS, 38 got IMNL, and only 1 patient had cannulated screws. And we've got 11 patients who had total hip replacements. Majority of these patients were female. 8 out 11 patients from the total hip replacement were female. The range of mean age were 69-year-old. So template was done. So from the 11 patients who had total hip replacement, template was done in 5 patients, and less than 50% of patients had template X-rays before operation. Timing of the templates: among 5 patients who had the template, 3 patients only had done same day X-rays, 60%, and 2 patients was done the following day. The X-rays were done next day after the injury. Adequacy of the X-ray: so among patients who had a template, we had 4 patients who got adequate X-rays, and 1 patient had inadequate X-rays. So as you see, the part of the right hip was not included in the image. Type of implants used: 7 patients had hybrid total hip replacement, 3 patients had uncemented, and 1 patient had cemented. So we presented this audit in the audit meeting that we've done. We do like every few months in trauma and orthopedics. So we circulated email to all junior and middle grade doctors about the hip fit protocol to request X-rays in ED for enough patients when we are planning to do total hip replacement, and teaching the resident doctors for the adequacy of perioperative templating hip X-rays. And also we had a chat with radiographers to organize like teaching session for radiographers to get adequate both hip X-rays with internal rotation for neck of femur fractures before moving them to the ward. Limitation of our study: there was only short period of time, 6 months, low number of patients. As you see, like there was only 11 patients ended up having total hip replacement. And also we've introduced a new pathway, which means that any patient who got now confirmed neck of femur fracture should be moved quickly from ED to an orthopedic ward without being reviewed by orthopedic team in A&E. This is also the limitation. Thank you very much.